Welcome everybody to Wednesday Night at the Lab. I'm Tom Zinn and I work here at the University of Wisconsin-Madison Biotechnology Center. I also work for the Division of Extension, Wisconsin 4-H. And on behalf of those folks and our other co-organizers, PBS Wisconsin, the Wisconsin Alumni Association, and the UW-Madison Science Alliance, thanks again for coming to Wednesday Night at the Lab. We do this every Wednesday night, 50 times a year. Tonight it's my pleasure to introduce to you Rob Stryker. He's with the Division of Infectious Diseases in the Department of Medicine in the School of Medicine and Public Health at the University of Wisconsin-Madison.
It's a mouthful.
Yeah, it's the Russian doll. I really like it. And you're going to be speaking about immune memory and regret, what biomarkers can tell us about the health of the immune system, and the risk of cancer. I now get to ask you the 5 questions I ask everybody. The rules are you get to answer any way that you would like. It doesn't have to be true, it just has to be believable. Rob, where were you born?
Cincinnati, Ohio.
And where did you go to high school?
Forest Park, Ohio, which no longer exists.
You killed it.
Yeah. Shortly after I left.
Wow. And then where'd you go undergrad and what did you study?
I went to Purdue and I studied chemistry.
So you went from Ohio to Indiana?
Yep, as far as I could get, as far as my money could get me.
That's good. And where'd you go for your advanced degrees and what did you study?
So I went to Washington University in St. Louis, still in the Midwest, and I got a MD and a PhD. The PhD is in microbiology.
Whew. And then where did you do your postdoctorate training?
Yeah, so my internal medicine residency was in San Francisco. I'm going to talk about that for a second. And then I did an infectious disease fellowship at Stanford and got my butt back to the Midwest.
Great. And how long have you been here at the University of Wisconsin-Madison?
23 years? 22 years.
22 years, good. And you're also in the Department of Medical and Microbiology?
Medical microbiology and immunology, yep.
And is your lab in this building?
It's in the microbial science building.
Yeah. Great. Well, thank you for all that. That's quite a saga. It always amazes me when people get PhDs and MDs, because that would be hard.
You just got to stay there a long time.
And that would be hard. Would you please join me in welcoming Rob Stryker to Wednesday Night at the Lab?
Thanks, Tom. Okay, so I hope everybody can hear me. Thank you very much. This is fun for me, at least, getting to talk to you guys about this. The key word in this title is biomarkers. It's kind of a big buzzword in medicine right now because we're trying to use markers to personalize things, not just genetics, but markers to say this person needs this and this other person needs something else. And really, this is a story of things that we've learned from 2 tragic epidemics, the HIV epidemic as well as the COVID epidemic. And, these are horrible things, but, kind of like World War II, technology happens. And so, we have sonar now and some other not so great things, courtesy of the challenge. And you may not realize it, but from these epidemics, we have learned a lot about the immune system and how to stay healthy, believe it or not. So almost all medical education starts with a case, so I'm going to do a case here. This is an unfortunate woman from Illinois who was really pretty healthy. She's 74, but she started having headaches over about a 2 to 3 month period of time and getting more confused and really lost the ability to answer questions. And so she had this MRI at an Illinois hospital, and they looked at it and they said, oh, this looks bad, send them to UW, send her to UW. And they thought that she had brain metastasis. These, I should use the pointer. These white spots here are bad. Okay, so she had actually just started medication for rheumatoid arthritis, something called an anti-tumor necrosis factor. There may even be somebody in this room that benefits. It's a great medication. It's made a lot of people much more functional. It's very common, but in her, it wasn't good. And so she came here and she got a biopsy, and it turned out this was not brain metastasis. It was actually a parasite called toxoplasmosis gondii. And this is, in my opinion, unprecedented in the human literature. And there's sort of two theories on why this happened. They could both be true. But theory number one is it was an aggressive Amazonian strain of toxoplasmosis. She's actually from Mexico and probably maybe got it from her cat in Mexico. But the other theory, and I should say that toxoplasmosis really only occurs in two settings. Symptomatic toxoplasmosis only occurs in two settings in the medical literature. A third of us are exposed, and so many of us actually have this parasite in our brains, but it's not growing and it's not making those ugly white abscesses. But the two situations where it's a problem are, one, if you're pregnant and you get it at that time, it doesn't do that to the mom, but it does it to the baby. It does it to the fetus, and that's bad. And then the other situation is if you have very advanced, very bad HIV and you're not on therapy. Even medium bad HIV does not make your immune system bad enough for this to happen. So she didn't just get anti-TNF therapy, which actually will do this to a mouse that has toxoplasmosis. She also actually had, in my opinion at least, a very stressed, weak immune system. And pretty much the only evidence that I have of that is that she had 3 times more CD8 T cells than CD4 T cells. So almost the rest of the talk is going to be about this imbalance between 8s versus 4s, both 2 types of T cells. Okay, so I already answered these questions, but yeah, I went to Purdue as an undergrad. I'm a Midwesterner. I went to St. Louis, and I met my now wife, who's also faculty and actually dean here in the medical school. I did a residency in San Francisco. I did not want to do a residency in San Francisco, but it ended up being a great thing because in 94, 95, just walking around San Francisco, you saw a lot of severely ill young men. And almost everybody that I admitted to the hospital, not everybody, but most of the people I admitted to the hospital as a first-year resident had HIV and died that year. But by my second year, we were putting combinations of HIV drugs together, and it was a miracle. It was amazing. The dead walked. It was really impressive. So I then did an infectious disease fellowship at Stanford. I actually didn't study HIV. I studied a different virus called hepatitis C because I saw that people were living long enough with HIV to have this other problem, hepatitis C. And then I followed my wife here, and everything's been great. I do want to point out that I'm not a modern immunologist, okay? I was never trained in immunology. I still don't know all of the different CDs, and I don't want to know all of the CDs. These are immune markers that specialists learn. They can tell you about the trees. I'm going to tell you about the forest here, how the forest functions as a whole with a bunch of different trees. If you want to know about a tree, ask a modern immunologist, not me. All right, so in our play here, we got germs. And not just any germs. I don't really care about the common cold. I don't care, that you were sick for a week this year and 2 weeks last year. We're talking about germs that stick with you from months to decades. So I already mentioned a parasite called toxoplasmosis. This can do that. There's also some gut worms, believe it or not. People have these. There's a lot of viruses that do this. HIV is the canonical example, but viral hepatitis, human papillomavirus, these are all viruses that stick with you for a long time. Sometimes just months, but often years. And then Mycobacterium tuberculosis, the bacteria that causes tuberculosis, people have this for months to years, often before they get sick. And then the canonical Wisconsin endemic fungi called blastomycosis. If you're up north in the forest, you might see signs. Hold your breath. The soil here has blastomycosis. This is another infection that can last for years in you. And then we're going to talk about the immune divisions. The stuff on the right are what's considered the innate immune system, first responders. That means they have no memory that we really know of. And the 4 classic signs, rubor, turgor, dolor, and calor. Swelling, redness, heat, and pain. I may not have done those in the right order, but that's inflammation. Inflammation is bad, everybody knows that. And inflammation is mostly cells called neutrophils, but a few lymphocytes. We're not talking about that. We're now talking about the adaptive or the memory immune system. These are trained soldiers, if you will. There's B lymphocytes, and then there's T lymphocytes that got educated in the thymus, and there's two types. Most of them are CD4s, but some of them are CD8s, and a few of them are something else, but those are very uncommon. I'm not going to talk about supplements. I'm not going to talk about boosting your immune system, even though the only thing that we definitely know does make a stronger immune system is exercise. Sorry, that's the only, we don't know what kind of exercise makes your immune system stronger. You may want to run home after this talk and look in your MyChart and figure out, well, gee, is my immune system weak? Fortunately, you have a complete CBC in your MyChart, shows you white blood cells, your lymphocytes, these various other cells. You might have a low number of lymphocytes, but even if that's unlikely, but even if you do, that count won't be broken down into the types of cells that we're going to talk about for the rest of the talk. So sorry, you're not going to be able to predict the future just based on your complete blood count. So this is the talk outline. I've already said inflammation is understood as bad. We've known this for decades. We know if you have, if like I don't brush my teeth enough, I have a little bit of inflammation in my gums, that's bad. That makes me more likely to have a heart attack. Inflammation in your toe is bad. That's all known medically, but we can't quantitate it very well. This talk is about what does chronic inflammation from a virus or from something else do to your adaptive immune system? And if it does that, what does that mean? That's what this talk is about. So part one is going to be an introduction to the immune system. Part two is two types of cancers, both caused by human papillomavirus. Part three is the thymus. Part four is a new concept called immune health grades. And then part five is lung cancer. I'll keep track of these parts so, if you're starting to get bored or overwhelmed, you'll at least know how far you are from the finish line. So this talk is mostly about this ratio between Wonder Woman, CD4 cells, it's big because CD4 cells are most of your lymphocytes, versus Batman. Those are both good DC characters. I mistakenly thought they were Marvel. My friend corrected me. Everything about Wonder Woman is wonderful. That's why she's called Wonder Woman. But if you read comics, Batman kind of has an edge. He can kind of be nasty at times. And that's what CD8 cells can sometimes be. Okay, so we got a 3-minute short video that's going to pretty much encompass the entire talk in the context of HIV, hopefully. But I'm going to broaden this concept to non-HIV patients throughout the rest of the talk. Oh. Why isn't the sound better? Sorry. That's not going to be enough.
However, people living with HIV have accelerated aging, heart attacks, and cancer more often than if they were never infected. New research, though, suggests that providers and their patients can address and hopefully avoid these problems. Even before HIV is able to kill CD4 T cells, the immune system makes extra CD8 T cells to attack HIV. This was a useful response when there was no medication to block the virus. But even after patients take medication and the virus is blocked, these extra CD8 T cells live on, throwing the immune system off balance and causing problems. While we know very safe ways to block the virus, we can't yet easily correct this imbalance. A key measure is the ratio between CD4 and CD8 cells. Ideally, this measure is above 1. Young patients who started therapy very early after infection typically initially have a CD4 to CD8 ratio less than 1. However, it may return to above 1 only after a few years on HIV medication. Most infected HIV patients spend many years or even decades with a ratio below 1. Many have 2 to 10 times more CD8 cells than CD4 cells. Studies have recently shown at ratios less than 0.4, people living with HIV are more likely to
Remember our
develop
case,
pneumonia,
she had 3
have heart
times
attacks,
more
or
CD8s
get
than
cancer.
CD4s.
It has taken scientists a long time to recognize the importance of returning the ratio to a level expected if HIV never occurred for several reasons. The ratio of young babies naturally falls within the normal growth from about 3 to 1. As puberty hits, a woman's ratio is slightly higher than men's until menopause. Many life experiences, such as infections, toxins, stress, and even mental illness can change the ratio slightly. We are only now starting to track the cumulative effects of these things. It is obvious that the ratio recovery is possible with the newer medications. This is true even for people living with HIV whose ratio is less than a tenth of what it should be. For people living with HIV, it is now clear that the provider and the patient need to work together to at least get the ratio to above 0.4 as quickly as possible, just like they partnered to get the viral load undetectable.
Okay, sorry about the snafu there. If anybody wants to watch that video again, it's already on YouTube. So we're going to talk about this ratio quite a bit, but I want you to think of a country, could be anywhere. We'll call it the Republic of Immunistan, and there's 2 political parties and there's majority rule. Almost all of the functions in at least the immune part, and probably all of the government of this republic, are carried out by trained technocrats. They do the things they're supposed to do. They're programmed to do these things. And at least in the immune system, these trained technocrats were educated at the thymus universitad. Okay? And these technocrats learn both from past infections, but also from vaccines. So I have a very short TikTok. I didn't make it. I did make the other one. That's going to explain how vaccines work, specifically messenger mRNA vaccines, the vaccines that we may have gotten for COVID. But really, most of this video explains all vaccines. Oh, wait, shoot. Well, I have to get it to start first. Okay, here we go.
You need to make this.
That's the
What is
messenger mRNA.
It's a part of a virus. A virus? Just a part of it, not the actual virus. They're called COVID-19. They have 4 cans and they're coming. 4 cans? Please.
So the messenger RNA goes away. It doesn't integrate in your body.
What is this? This messenger told me to make them. I've never seen these before. I'll make some new antibodies to get rid of them. Seize the forks. Nice body. Gonna make this place my new home. 4 cans. Seize them.
Okay, so you get the idea. That's a trained immune system that quickly deals with the problem. An untrained immune system can also deal with the problem, but it takes longer and there's damage occurring while it's learning to deal with the problem. Okay, so let's see if we can go back into presenter mode. Shoot, come on. There it is. Okay. So again, the immune system is supposed to work together. They're not opposed to each other. CD4 cells and CD8 cells should work together. They're on the same team 90 to 95% of the time. But the natural, if you will, order of things is to have more CD4 cells than CD8s. We're going to talk about what about if the natural order is not working as evolved or designed or whatever way you want to think about it. And I realize this analogy of the French Revolution, the peasants always outnumbered the elite. So forgive me on that, okay? But the French Revolution is an example where the political, where the underclass rose up and decided they're going to do things their way, and kind of chaos happened. Okay, so what would cause the CD8s to rise up? Well, one thing for sure is HIV. Believe it or not, hepatitis B, when it's chronic, even if it's not that bad, also nudges things towards the CD8s becoming more present than they perhaps should be. And another example we're going to talk about, well, what if you don't have a thymus? Or what if your thymus is removed? We've always known for little kids, thymuses are important. But I was taught in medical school, and frankly, most physicians think once you get age 50, there's nothing to learn, immunologically speaking. Okay, you know all the tricks, so why do you need a thymus anymore? Okay, so most of what I'm going to talk to you about is largely because Dr. Christina Sanger, who's a professor of colorectal surgery, came here maybe 9 years ago and was asking me, how come anal cancer is going up? Why are we having more cases? And I'm like, I don't know. But at least in the people that have HIV, one thing that we should look at is this ratio. And it's not very clear here, but if you can tell, there's a light blue bar that's the normal range, both for the CD4 counts on the left as well as a smaller blue bar on the right for the CD4 to CD8 ratio. And then this yellow and blue lines are lines indicating what the count or the ratio is for people who either don't have disease or do have high-grade disease or actual cancers. And what you can see is the orange line and even the blue line is pretty close to the light blue here. But for the ratio, the discrimination between normal and abnormal is much easier to find, okay? And so that was news when we published that. We've now published this 4 different ways and 3 different sets. This is true, and 2 other groups have also published this. So everybody agrees now that the ratio for this cancer is a better biomarker than just the absolute CD4, which was news. So let me just tell you a little bit about anal cancer. It used to be very rare. It's a malignancy that arises obviously from the anus. It's always squamous cell, and it's almost always preceded by precancerous lesions years before the cancer develops. And rare, but it's increasing in incidence and prevalence. And we now know, but didn't know 2 or 3 years ago, can prevent the cancer from developing by treating the precancerous lesions. We've known this about cervical cancer for decades, but anal cancer was so rare that we didn't know that. So this is just a little bit of data that shows rates of anal cancer are going up, and the percentage of cancer deaths from anal cancer are going up. And even though it's going up, for decades we've not really made any improvement in the treatment of someone who's got anal cancer. We don't really have any new drugs that work. We don't have any new magic. But we do now know that if we catch it before this, we can treat it. And we know that because of this very large anchor study that was just published about 18 months ago, where they looked specifically at people with HIV, where we knew there was a high risk of cancer. We did a highfalutin survey of these people, and we treated half of them before they got cancer, and half were not treated. They were just monitored. And the separation between the blue line here and the red line says the treatment worked, and that people who got treatment had half the chance or less of actually developing cancer. So that's big news. So now I want to contrast anal cancer caused by HPV with cervical cancer caused by HPV. Obviously, only women get cervical cancer, whereas anal cancer actually occurs in men and women. Anal cancer occurs at older ages, which is probably one reason why it's increasing, but it's not by any means the entire story. And actually, one of the biggest risk factors for anal cancer is, at least in women, having had precancer in the cervix. So that's a risk factor. We have great screening recommendations and an entire industry built on catching cervical cancer before it's cervical cancer. These are pap smears that people get, but we have almost no guidelines within anal cancer. We don't have a good plan on catching anal cancer. And importantly, we have very few people who know how to do the best way of screening. Getting a pap smear of the anus is simple, but it's not a great test. So to do the best test, we need to train a lot more people. So I'm interested in the question, since clearly anal cancer, the ratio is important. Is it important in cervical cancer? And unfortunately, we don't know because we don't study a lot of women, and we don't have women with HIV to the same extent in North America as we do men. But we're collaborating with Dr. Flavia Matuva from Macquarie University in Kampala. Oops, sorry, didn't mean to do that. And we're hopefully going to answer the question, both in women with HIV as well as women without HIV, is the CD4-CD8 ratio a risk factor for cervical cancer or precancerous lesions? So this is some data that I generated with Daud Siraj, who hooked me up with investigators in Ethiopia. And this just shows, number one, that if you're on treatment for HIV, your ratio goes up. And the red lines here are actually the women. The pink is the average. And then the light blue are the men. And young men's ratios on treatment do not increase as fast as young women's do. Particularly old men are frankly the worst. And what I'm not showing you here is the consequence of having that ratio not recover fast actually makes it more likely, in Ethiopia at least, to get tuberculosis, which is bad. So there's a clinical consequence of not having your ratio rise fast. So this is, we're now on part 3, so you're halfway done, guys. But the thymic function, the need to recover this ratio, basically, the bigger the thymus that you have by ultrasound, the more thymus you have by ultrasound, the more likely you are to be able to make that recovery and get at least close to 1, if not to 1, despite having a low ratio with HIV. And so this is frankly the single paper that links the ratio to the size of the thymus, but I'm going to show you other data, and there's a lot of circumstantial evidence that says what determines your ratio to a certain extent is how much functioning thymus you still have. And I'm going to speculate here that, 30 years ago, before I started practicing medicine, we had aspirin and that was about it. If somebody had a heart attack, kind of sucks, you say retire, try to live a stress-free life. We didn't have beta blockers. We didn't have angiotensin receptor inhibitors. We didn't have any of these things we now have that essentially give your heart a chance to recover from a heart attack. And now that we have these medications, hearts actually do heal after a heart attack. At least that's what all the evidence says. So maybe we need to come up with something that allows the thymus to heal. Maybe we need stem cells for the thymus. I don't know. But what I'm trying to argue in this talk is we have markers to say this person's immune system needs a rest and maybe a boost in some way that we have not really had before. Now, you might be asking, Rob, this is fine for people with HIV, but most of us don't have HIV, and why should I care? Well, this is a paper out of Tony Fauci's old lab, like 6 months after he retired, and they followed 100 people over 30 years who had low CD4 counts. And we started accumulating these, everybody did, because we'd see people who looked like they had HIV based on their clinical presentation, but didn't have HIV. And we didn't know, was that just a bad day and you're fine after you recovered? Or was that a progressive disease like HIV where you're gonna have more and more and more bad days? They followed these people for 30 years and they said, it's not as bad as HIV, but clearly you're going to have more bad episodes because your CD4 count is low. And those bad episodes look like the bad episodes you have if you had HIV. And most importantly, it's not genetics. 7% had genetics. Most of them did not have a simple genetic reason for why their CD4 was low. But the paper did say some of these people also have altered CD8s, and they grouped people by these altered CD8s, and we said, well, wait a minute, that sounds like a ratio. Why don't you give us that data? And so Dowd and Liz Duke and myself wrote to the New England Journal of Medicine, and they responded, and they're like, good point. We only have 100 people. The ratio doesn't add a lot of information, but they published what the ratios are. That's these 3 columns here. And interestingly, the people with the most normal ratios were the least symptomatic. That's the middle purple. And the people who had very few CD4s and very few CD8s, or a whole lot of CD8s and very few CD4s, those were the most symptomatic. So it didn't necessarily add more fuel to the ratio fire, but it definitely was consistent with the ratio being important, and none of these people had HIV. Okay, so on to more about the thymus. Just about 3 months ago, there was a large analysis of people over 50, most of them were over 50, who needed coronary artery bypass surgery. And I didn't know this, but sometimes when you're trying to fix somebody's heart, it helps to get the thymus out of the way. And so actually a third of these people or so had their thymus removed just so they could finish the surgery without the thymus being in the way. And 2/3 did not have their thymus removed. And what you see from these yellow and blue lines are the people with the thymectomy died more frequently and sooner than the people who did not have their thymus removed. All these people are middle-aged to elderly. All these people, sorry, they all died at some point. But the people whose thymus removed died sooner. And they didn't just die sooner, they died with different kinds of cancers. So anal cancer was one of the things, but it was mostly lung cancer, prostate, breast cancer that occurred more frequently in the group that had their thymus removed. These are very common kinds of cancers, but again, it suggests the thymus is important. Remember, this is where the CD4s and the CD8 cells get educated, is important for cancer surveillance. Most of the last few decades of immunology have been aimed at learning how the soldiers get trained and figuring out, is this soldier trained to be a sharpshooter or to operate a tank? Is it trained to fight COVID or is it trained for influenza? That's most of modern immunology, very simply. But what we're talking about here are essentially non-trained, non-technocratic functions of the CD4 cells and the CD8 cells, and they have them. And if you don't have enough CD4 cells, you can't make this gamma interferon, you can't make other cytokines, and you can't promote the B cells to make antibodies the way you should. And the CD8s also have antigen-independent functions that seemingly are important. Okay, so now we're on to part 4. You're almost there. So just 2003, a large group of epidemiologists were trying to answer the question, yes, age is a big risk factor for why people die of COVID, but not every 80-year-old who gets COVID dies. And some 40-year-olds who get COVID do die. What's going on? What can explain this dichotomy? And so they had access to a large 50,000 patients from 15 different large cohorts, most of which were not designed to answer the COVID question. But they decided to group people into 4 groups. So the left and the right of the screen are just 2 different ways of representing this. The people with a good immune system that was normal, they had more than 800 CD4 cells, and their ratio of 4s to 8s was above 1. I was really surprised that they could find a phenotype for people that had CD4s more than 600. I thought that was pretty good. But less than 800, ratio greater than 1, that was stressed. Grade 3 is more than 800 CD4 cells, but now your ratio is less than 1. There's more CD8s. And then grade 4 in their cohorts is bad on both counts. Make sense? Okay, so basically, as you get older, you could still have a more normal immune system. Normal immune system being blue here by the immune health grades. But the older you get, the less likely your immune system is still going to get a grade of 1, which is good, and the more likely you're going to get a grade of 2, 3, or 4, which is orange, green, or gray. And the more you have a non-grade 1 immune system, the more likely you are to die from COVID, but also influenza, also sepsis, also getting a heart attack, and a few other things that I'm not going to talk about. So they're basically making the argument, if you're immune, you could be fine. It's a biomarker. It doesn't mean you're going to die. But if your biomarker is not good, the chances that you're going to have problems are higher. So interestingly, there's a gender effect here. You may have guessed, since Wonder Woman is better than Batman. But women are more likely across the age range to have a normal, more CD4 cells than CD8 cells, more likely to have CD4 cells above 800 than men are. And on the right, you can see the 2 lines. The pink line is women, the blue line is men, and across the ages, basically, the women always win. Sorry. So why are women more immune resilient? That's the term they use. Not necessarily immune better, just more resilient than men. Well, it's not just culture, okay? This is true in mice as well. Women have more chromosomal material. If you remember from high school biology, women have 2 X chromosomes. We, men, have an X and a Y. The Y is kind of small. There's more genetic material on the X. So that's good in this setting. But women also actually have more autoimmunity. They're more likely to have lupus. They're more likely to give other rheumatoid arthritis, other immune diseases. So yes, they're protected from bad immune outcomes, but maybe they also have, more. And specifically on the X chromosome, there is something called toll-like receptors. Not all the toll-like receptors, but specifically toll-like receptors 7 and 8. And we were all taught that the X chromosome gets inactivated, so you have the same, whether you're a man or a woman, you have the same amount of expression from your X chromosome. Turns out that's not 100% true, and at least for toll-like receptors encoded on the X chromosome, women have more. Sorry. Okay, we're getting there. I've already shown you that there's this gender effect, and it compounds. So the 2 of these things factor together. I don't think this is the only reason why old men do particularly bad with COVID. Testosterone probably has something to do with it. But it is certainly it correlates, it fits with the data. You might ask yourself, okay, but if I make it to 90 and I'm this old crusty guy, I must be tough as nails, right? And I'm sorry, I think this is Yellowstone 1873. Yeah, somebody's seen the movie or the TV show? This is Sam Elliott, very crusty but tough character in the Yellowstone TV series. He must be tough, right? And then here's a more modern grandpa kissing his friend from The Simpsons. Obviously, Sam Elliott must have better genes, right? Because he made it to 90 without any help from vaccines. That must be good, right? Well, it turns out that if you survive diphtheria, which very few people did 100 years ago before there was a vaccine, you had no autopsies. They didn't find thymuses in adults until you got the vaccine, and you could survive diphtheria without the help of a vaccine, okay? And there's probably a lot of things that actually allow your thymus to persist into late age, and one of them is probably vaccines. Those of you who are married know that women are better in charge, but particularly your thymus has evolved to make sure there's more CD4 cells than CD8 cells. They're not just training lymphocytes to react with specific antigens and killing the lymphocytes that auto-react. The thymus is making sure we send out from the university a few more CD4 cells, maybe twice as many as CD8s. And if that's not happening, it's going to kill a few more CD8s just to maintain the blue party, the CD4 party in charge. Okay, so we're now trying to judge, are these immune health grades the same thing as a ratio, or is there something else? And what I can tell you is that if you're looking at people with damaged immune systems, particularly HIV patients, the ratio is what determines the outcome. Almost everything I've told you from HIV patients is on the extreme left of this slide. The CD4 cells, the ratio is not just below 1, it's usually below 0.6, sometimes below 0.3, before you can see an obvious effect on a few hundred patients. But if you're trying to measure people with relatively intact immune systems, everybody has to have an immune system above 1, not quite, but sort of, or at least near 1, and the amount of CD4s end up mattering. So this is HIV data. We'll flip back to HIV, but it's showing you all the cancers that are more common in people with HIV who are treated and have low ratios, okay? And basically every cancer that we could have, even 50 people in the North American study, there was, if you added all those cancers up, there was an effect. But if you individualize the different cancers, like cervical cancer, this is something called a forest plot. So this line here, if you cross that line, that means you're non-significant. But if you're to the right of the line, that means there's a significant effect. And at the top here is all cancers. So all cancers together are significant. This is the same slide, but just fewer things. And I'm showing you only those things that essentially have a significant effect. And the two things with the most significant effect are lung and anal cancer. So these are the cancers that are particularly common when the ratio is low in HIV patients. I've sort of already told you about the anal cancer. The lung cancer is really kind of surprising. It's not a virally driven cancer like the other ones. Why is this happening? And particularly interesting is if you smoke, your ratio is high. This really bummed me out at first because I was desperately looking for things that would make your ratio high. And I found out the one thing you shouldn't do, for sure, is smoke, and it raised your ratio. So that kind of threw me for a loop. And this is the data from people with HIV, but it's also been reproduced in older studies in people that don't have HIV. Smoking status makes your ratio a little bit high. Interestingly, though, if you smoke long enough that you damage your lung, whether you have HIV or not, now your ratio goes in the tank. We know with cancer, the ratio lowering comes first, and then you get the cancer. With the lung effect, we don't know that yet. We need more data, but we're interested. And so we're studying lung cancer in the ratio. And where are we doing this? Well, we're doing it in one of the two most polluted places in the world, North Punjab in Pakistan. So this is on the left, you see the area. These are highly industrialized, highly polluted cities. And, you know, when we have a wildfire in Canada or when the Californians have a wildfire, we get this kind of air too, but we only have it for a few days or a week. They live in this air all the time. And it's actually not too surprising that they live in this air. Part of it is they don't have an EPA, but part of it is the geography. So that circle up there between the mountains, this is where the pollution sits. In North Punjab, as it's generated, it has almost nowhere to go. And the other blue circle is the most polluted area in the world, Bengal. And again, the pollution just sits there. It has essentially no place to go. So to summarize, what I've told you is the immune system faces a lot of challenges, infections, aging, and these challenges, if they're cumulative, they make us more vulnerable for the next challenge. And these challenges can erode a well-functioning CD4-dominated immune system into a more vulnerable CD8-dominated immune system that's now more susceptible probably to autoimmune diseases, but definitely to cancer. And all cancers are more common with weaker immune systems, but there's two, for reasons that we don't understand, but we can talk about it, that are particularly common when your immune system gets unbalanced in this way, and that's lung and anal cancer. We need to figure this out more. You know, I hope there's Wednesday lights in the lab for years to come, but right now I don't know why those two are, but I do have a lot of people that I want to thank. Christina Sanger has accumulated a ton of data, not just from the UW, but from the nationwide VA. It's a lot of work. Dowd Siraj helped me initially get data from Ethiopia. Austin Hewitt is a colorectal trainee, surgical trainee that's been working with Christina and I. This is our Pakistan team, Dr. Umar Saeed from Islamabad, and two graduates of King Edward. Liz Duke has been helping me think about this for a long time. I mentioned Flavia Matuva, who's at Makerere University in Uganda. And I didn't show any of this data, but Ajay Sethi has helped me access data that's really influenced my thinking a lot. And he also does great work on science, or on vaccine miscommunication and misconception. So if you get a chance to hear Ajay talk, you should grab it. That's my talk. Oh, yeah. Yeah, it does not. We test it in people that have HIV. We occasionally test it when we're trying to figure out, is this person immunodeficient in some way? One of the reasons why I like this idea so much is because it's actually pretty cheap to do, and hospitals all over the world can do it, but we shouldn't do it unless we have really good understanding of what it means, and ideally how to fix it. So we don't have those things yet, but at least we can now, any hospital essentially could start to quantify this and try to figure out, you know, do I have a lot of people in this category or not? Yeah.
So my question follows on what you said.
Give me a chance to come up and give you the microphone, Jim.
Yeah, and I'll try to repeat the question, sorry.
So follows on. So I walk into your clinic right now,
Yep.
and my ratio is bad.
Yeah.
What do I have to worry about?
Well, depends on what we mean by bad.
Oh.
Okay, but you know, essentially, if you were 30, I don't know that I would do anything.
I'm not 30.
If you're a little older, we might talk about a little more aggressive cancer screening, but that's not evidence-based. It's just something we would talk about. And it would still be influenced by, like, do you smoke? If you do, you should stop. You know, how much red meat do you eat? If you eat a lot of red meat and bacon, you should eat less. So all these things still apply. And I think I said we don't know what kind of exercise is best, but probably just like you're not as strong as you were 20 years ago, exercise probably helps your immune system stay more balanced.
Even when you're old?
Well, we don't know that yet, but we know in an HIV patient whose immune system is most likely more damaged than yours, if they sit on the couch, they don't get better. And if they exercise, they can. Yeah.
I have a question about the CD4, CD8 ratios in pregnancy.
Yeah.
Has that been tested at all?
I don't think so, to be honest. I think you're right, and it's something I've been looking for data on, but there's a lot going on there. Because we know in pregnancy, you're a little bit immunosuppressed, you're trying to not attack the fetus, but also your hormones are different. Yeah, so I don't think we know. That's a great question, though. I really am interested in that.
Going out on a limb with that different. Other questions? I'll be right back.
So family doctors recommend that the boys or girls get the HPV vaccine?
Yep.
Is that something you think?
Well, absolutely.
Yeah.
I think it's clearly beneficial in both boys and girls. We have clear data from multiple countries that is true. There's a community effect. If we're giving it to boys and girls, everybody benefits. But also, I have some pretty sexually experienced patients, and we don't know if it works in those populations that have already seen HPV. And most people have seen HPV regardless of how many sexual partners, well, not regardless, but if you've had sex, there's certainly a chance you've seen at least one HPV.
Thanks.
Other questions? I'm going to drop it off here and then come down to.
When you were showing the forest plot, you said that CD4 to CD8 ratio seemed kind of significant over like the sum of all cancers.
Yep.
Were there any in particular where it was very much not significant?
That's a great question. Actually, I'm particularly interested in breast cancer because there have been a few non-HIV studies where there may be a different effect. And I'm sorry, the question was about, was there any cancers, and all these patients had HIV, were there any cancers where the opposite was true? Could be, but not cancers common in men in North America that have HIV.
Thank you. This is a wonderful talk. I'm relearning immunology as I'm listening. It's hard. Yeah, it's complex. This is a completely random question in a sense, but since you're an immunologist or you know more immunology than I do, I thought I would ask.
Sure.
So I listened to a podcast of a review of a paper looking at long COVID, and they were looking into biomarkers for that, and one of them was looking at low levels of cortisol. And so I'm curious as to what your thoughts might be of the connection of cortisol to the immune system itself.
Yeah, I think it's a great question. Her question was cortisol, and one of the problems with this data is we measure these CD4, CD8 ratios whenever we see the patient. And there's probably, but I can't tell this definitively, there's probably a slightly different ratio in the morning than in the afternoon. And sometimes you get slightly different numbers in the right arm versus the left arm. So, you really have to average these things out over large populations, but at least some of these effects we can find in relatively small groups of a couple hundred. So the effects are clearly there, but again, it depends upon which effect, and I'm sure you're right that cortisol has some role. I just don't understand it at all.
Other questions? If not, thank you very much.